right, well, good morning. I guess if we're on CFF time, so we should stick to the timed agenda that's been given to us. It's just so happy to be back together, see all your faces, welcome you back here. It's wonderful to be in Philadelphia, to be at the NACFC, and we are at this is DG08, Genetics and Genetic Counseling. And we're going to work together through the tech of the day. I'm Eleanor Langfelder-Schwind. While I don't have any disclosures related to this presentation, I do have some grant funding for genetic counseling from both the CFF and Vertex Pharmaceuticals. And on behalf of my co-presenter, Sumita Gate, who has no disclosures at this time. So we have a pretty packed agenda, which is one of the reasons we wanted to get started quickly. We'll go through a few announcements, have a presentation from the CFF Education Committee. We have 4 really wonderful speakers who will be introduced shortly by Sumita, and we'll have plenty of time for questions and discussion. In terms of announcements, actually I'm going to add an announcement regarding the questions and answers. If everybody could open the app for the conference and choose the session and look to questions, and you can, any questions you have during the speakers' presentations, you can just type them in and we'll be monitoring them and we'll be leading that discussion in that way. We hope to be able to take a few questions after each speaker and then again at the end have plenty of time for discussion. If you have any questions about the app, ask your neighbor, and if I see Brandy's back here, so we can call to her if we need her to. All right, and I told me if I clicked the slide that I'd be able to do this. Okay, good. So in terms of announcements, the National Society of Genetic Counselors CFTR SIG meeting, Special Interest Group meeting, will be held tomorrow from 8 to 9:15 a.m. at Panera across the street, 48 North 12th Street. Thanks to Karen Rary for getting us organized with that. And our CEUs for this meeting will be Category 2. If you are a genetic counselor at this meeting and you're not part of the CF SIG, please come and meet us anyway, because we would love to just build community as part of this meeting. We also have a lot of accomplishments to kind of talk about and maybe brag a little about this year. Genetic counselors were represented on this year's NACFC Program Committee, the CFF Education Committee, as well as 4 genetic counselors on the CFF CRMS CFSPID Guidelines Committee. The CFF also endorsed recommendations for genetic counseling of parents of infants with a positive CF newborn screen. We'll hear more about that from Dr. Parad in a little bit. And then here at NACFC, in addition to this meeting, we have a clinical genetics workshop on Saturdays featuring 3 genetic counselors who will be speaking, as well as tomorrow's Lunch and Learn on how to read a CF genotyping report featuring 5 genetic counselors. And then, last but not least, our own Becky Dara will be a featured speaker at Plenary 1, and we're just so thrilled and excited to see what she has to say. And without further ado, I welcome Marissa Rollins to talk about the CFF Education Committee.
Good morning, everybody. So I'm here today to talk about the CF Foundation Education Committee. I am actually the committee facilitator, and as was mentioned, this is the first year that we have a genetic counselor joining us on the Education Committee. It was raised by members of the committee that as we advance into this era of modulators and we have more education on pregnancy and everything like that, that having a genetic counselor as part of the Education Committee was really vital to continuing to approve and provide high quality education material. So really excited. We have Kim Foyle joining us on the Education Committee this year. Round of applause. But we are a multidisciplinary group of adult and pediatric specialists, and our term on the committee is 3 years, and the application process is based on experience with cystic fibrosis, experience creating, reviewing education materials, and ideas for development of CF education. So the next round of applications will be in spring of 2024. So here's a list of current members with a photo of the committee from last year's virtual meeting at NACFC. Not all current members are pictured, and this list doesn't include members who are rolling off the committee this year. So you can see we have quite the robust group. So here's what we do. So the Education Committee reviews education material that is submitted to us for approval, and materials are vetted for accuracy, applicability for care centers across the country, and they meet a recommended reading level of about the 8th grade. Materials in the CF Education Resources Guide are routinely reviewed to ensure that they're still available. And the committee also reviews education abstracts for NACFC each year. If you're interested in looking at those are at the CF Foundation booth under the pillar that says CARE towards the back of the booth. And so it's been a while since we last presented at this meeting. I bug Eleanor and Sumeta every year to have a committee member come speak to you all. But since it's been a while, we wanted to share some things that have been approved since 2019. So we have 4 materials, well actually 5, but one document on wildfire smoke and cystic fibrosis and things to prevent particles from entering the lungs, the Right CF screening tool, which was produced by the National Organization of African Americans with Cystic Fibrosis, the herbal product information sheet, which was approved previously by the Education Committee but was updated recently, and as well as 2 CF Rise quizzes, one on CFRD modulators and another on emotional wellness. So here is a couple images of those materials. These can all be found in the my.cff resources library. If you're not familiar with my.cff, it's a platform that hosts the resource library, the listservs. It's where the annual report is completed every year, so it's really the one-stop shop for care teams. Speaking of the resources guide, the 2022 edition, it's been shared on my.cff and it can be downloaded from the resource library. It's a great tool. It's about 80 pages of the known education materials for cystic fibrosis. It includes information on genetics, nutrition, guidelines, so it really is just chocked full of great information. So it's also, if you want to have it emailed to yourself, you can go to the CFF resources section in the NACFC app, and it's there, and you can add it to your cart and have it emailed to you. So if you're trying to find a resource and you're not sure where to start, my recommendation would be to start at cff.org or in the my.cff resource library. If it's in print, if you're looking for something that is hard copy that you can write on, hand out, I recommend checking the clinical education materials order form on my.cff. When you log in, there's a little tile with a shopping cart. You click that, and that will open up the form for you. And if you're having a hard time locating something, you can just ask us. Our email is resources@cff.org. You can also, as I mentioned, order education materials. Here's the little shopping cart I was mentioning. This is also where you would order the clinical trials materials. So to access my.cff, you would just go to my.cff.org and log in. If you're having difficulties and you're not seeing some of these tiles, you might not be necessarily added to your team's roster. So you would need to just contact your program coordinator to make sure that you are listed as a member of the care team, and then that will open up many of these tiles for you to access. So when you click into the order forms, this is what you see. All of the all of the materials are arranged by topic. This makes it really easy to navigate through. You add things, however many copies you would like, and then you'll update your shipping address, review, submit. So how can you be involved? We encourage you to submit education abstracts for NACFC, respond to any surveys, notify the Education Committee if there's something that is out of date or unavailable, particularly in the resources guide. We do a in-depth update every 2 years and a more minor update in between those years. So if there is something that you find that's unavailable, out of date, or even something that's been created that you want to have added, you can reach out to us at resources@cff.org and we'll take care of that. You can also distribute education to the CF community and submit resources for the Education Committee to review, again, to that resources@cff.org. And I think that's all my slides.
Thank you.
Thanks. Do you want me to take questions, or
Sure.
are there any questions? Did I tick all the boxes? Okay, thank you, everybody.
Thank you very much, Marissa. I always learn something new from what you tell us each year, so thank you. And I'm going to introduce our learning objectives and the speakers who will be covering them. And I'll introduce all 4 speakers now, and then as it's time for each of them, I'll just say, and please, I'm inviting the next speaker to come up. So we are very, very happy to have Sabrina Sherwood. She's the lead clinical pharmacist at the Cystic Fibrosis Center at St. Luke's in Boise, Idaho. I heard her speaking last year at the CF conference, as many of you may have, and we were really impressed, and we're excited to have her here today. And we're also very happy to have Kim Foyle here and listen to her unprecedented, although whenever I say that word now, I think pandemic. So unprecedented case. And Kim Foyle is a genetic counselor at Medical University of South Carolina, and she will discuss ethical considerations and potential maternal fetal risks, benefits, and unknowns of in-utero modulator treatment for CF. And our next 2 presenters will be Tina Koshari, and Tina is a senior genetic counselor at the Division of Genetics and Genomics, Department of Obstetrics and Gynecology and Reproductive Science at, yes, that's right, at the Mount Sinai School of Medicine. And she will describe genetic counseling recommendations related to an intervention for adults with CF seeking counseling for reproductive planning. We're happy to have Tina. And then we are very pleased to have Dr. Parad back, and he will describe genetic counseling recommendations for parents of newborns who screen positive for cystic fibrosis. And he is the director of the Newborn Genomics Program and associate professor of pediatrics at the Brigham and Women's Hospital, Harvard Medical School. So we're very happy to have Dr. Parad as well. Thank you very much to our presenters, and we're really happy each year to have a multidisciplinary group at this session. So if this is your first time, welcome. We're really happy to have you, and we're also obviously very happy to have genetic counselors and looking forward to seeing all the genetic counselors at the CF SIG meeting tomorrow. So with that, we will, let's see, I'll go back.
I'm just going to exhale it.
Oh, yeah, that's right. Yep.
So we'll welcome Sabrina to the podium while we're getting our tech set up.
Thank you.
Okay. So you have to click on this. So if we click on this, no,
Does this work?
It doesn't. So what seems to be happening is this. See if the arrow works first.
This guy?
Yeah.
Yeah.
Okay, awesome.
We're going.
Okay.
Okay. Well, thank you, everyone. I have to say I'm so excited to be back here in person, see faces, and especially happy to see all of you so early in the morning. So thank you. Thanks so much for being here and being willing to get a little nerdy with me today. I know it's early, but I'm going to try to hold back my pharmacy nerdiness a little bit. But you're going to get some of it, so hold on. So today, in a really short amount of time, we're going to examine why this topic matters. And we're really going to dive into the specifics about pregnancy and lactation in the area of modulators. We're going to look at the evidence kind of behind use of those products in our mothers and then in the infants as well. And I'm going to show you just the latest and greatest, what's out there for the evidence, which, no surprise there, it's not a ton. But we will navigate that, and I'll show you how to have these conversations with patients. So why does this topic matter? Well, we know that all of our patients want to be on modulators, right? And at this time and day, over 90% of our adult patients are eligible for modulator therapy based on their genotype. So we've made huge advancements. And we've seen a trend in pregnancies, so we need to be able to address that. If you look at 2019, they recorded 310 pregnancies in that year, and then it doubled in 2020, right? So, and I'm not sure yet what the 2021 numbers came out to be, but I'm guessing it was higher. So we need to know how to tackle this rise in this trend. So why? Why are there so many more pregnancies all of a sudden? Is it a baby boom? That's what we seem to be calling it, right? But in this survey that was conducted in 2018, they found that women with cystic fibrosis want to have children in the future. And this was before Trikafta. So women want to get pregnant, and now they may be able to just a little bit easier. The thing that doesn't match, though, is that our women with cystic fibrosis also have a lower rate of being on any form of contraception. And so this was a survey done comparing CF women to the general population, and they found that less women were likely to have ever been on any contraceptive form. And so I really want to take a second here to say all of us in the room, doesn't matter what your discipline is, doesn't matter your background, we can all have a conversation with our patients to say, hey, have you talked about contraception? You know, pregnancies are on the rise, and let's talk about it and get them to another medical provider who can provide that if you can't specifically. But I think it should be each of our mission. I hope you all take away today that it's a big thing. Unplanned pregnancies in any population is something that's stressful, right? But in the cystic fibrosis population, it especially can have very meaningful impacts on health, mental health and physical health. So we need to be able to address that. So do we think modulators increase fertility? Well, Jane and colleagues hypothesized a few ways that this could be happening. They did an article in 2021 that reviewed some ways that they think modulators may be impacting this. They found, you know, and this isn't hard to believe, but through improved lung function and improved nutrition with our modulators, mom's taking care of herself better, so maybe baby is doing better as well. They also found that modulators may be able to increase pH of cervical mucus and decrease viscosity, therefore allowing conception to occur easier. And this, I want to show you really quickly, this is what I will refer to as the mother and child-centered care team. I've had a few different ways that I've broken this model up before, but this is what seems to make the most sense. So for me, you know, having the mom and baby in the center of the care team is very important. We've got lots of people who surround that care team though, right? We've got a cystic fibrosis team, we've got maternal fetal medicine, OBGYN, we've got the primary care provider, the pediatrician. So how do you navigate all these players and all these hands in the pots when mom needs to get some advice, you know? Do I need to continue this med? Well, sometimes the CF team and the OBGYN may have differing opinions on that. And so one of the things that I hear frequently in clinic when I see my patients is, I'm frustrated, nobody's communicating, I don't know what I'm supposed to be doing. Do I stop the azithromycin? Do I continue it? What's going on? And so I think this, I hope we all can come back to and say, how can we make this circle just a little bit better? And I think you all here are in the perfect place to do that. I think you guys have a real sense of being able to connect different parties, especially that maternal fetal medicine, OBGYN group, and the cystic fibrosis care team, but really anyone, right? And I think this is so incredible that you have this opportunity. And so I hope today you take away a few ways to make this communication just a little bit easier on you, on the teams, and for the patient, keeping mom and baby in the middle. All right, so let's dive into pregnancy. Well, we know that the question of if we should continue on modulator in pregnancy is not a simple yes or no answer. And so there are 4 topics that I like to discuss with patients when it comes time to make this decision. And sometimes this is before a mother gets pregnant and they're planning on a pregnancy. But unfortunately, a lot of times they're calling me after their first pregnancy test and they're saying, Sabrina, I don't know what to do. What do I do with my medications? I don't want to harm my baby, but they had an unplanned pregnancy. And so these are the 4 things that I like to cover with moms. So on the left-hand side, we have the pros for continuing a modulator in pregnancy, and on the right, maybe some reasons to consider not to. So I like to talk to mom about her health and how her health can indirectly benefit the baby. That's one pro of continuing a modulator in pregnancy. And then also avoiding this modulator withdrawal phenomenon, which we don't have time to go into today, but this Trimble and colleagues paper is very well known. You can have life-altering consequences for stopping a modulator abruptly, and so it's very important at least to have the discussion of continuing a modulator in a very serious matter. On the other hand, though, I like to be very transparent with patients. I don't know everything about modulator use in pregnancy and lactation, and I like to be very transparent about that. I go through all of these articles with the patients if they want to. Usually it's just a summary, but I can't deny that I don't know everything about, that I do know everything about modulator use in this population. So let's dive into that evidence. So animal reproductive models are one of the best tools we have even now to kind of make this decision. So this information was adapted from a 2021 article by Jane and colleagues. Please remember when you're looking at this chart though that these components were only studied in rat and rabbit models as the individual components and not the compound that they're administered as today. It's known that these components cross the placenta and therefore exposure is inevitable, but what does that mean? Well, I gave this chart kind of a plus and a minus sign because I think it can speak to both sides of the argument. On the pro side, it appears that the individual components do not negatively impact fetal survival even when the mother was given toxic doses. But on the con side, they did see congenital abnormalities in the tezacaftor group, but in no other group. And again, these were at doses that would not be used in a human. They did find decreased weight in the fetus in all groups except lumicaftor, but again, toxic doses. All right, so then let's look at the real world evidence, right? Because that's what I feel like really matters and what moms use to make their decisions. So on the pro side of this, I think that this, I will just say the summary is that I think it's positive. I think it's a reason to continue a modulator in pregnancy, but we'll kind of look at the specifics. So in 2021, that first article there was by Dr. Taylor Kauser and colleagues, who you're gonna hear a lot from this conference. And they followed 45 pregnancies to delivery. They were all exposed to Trikafta. No infant complications were deemed to be related to maternal Trikafta use. However, 5 of the complications did occur, seem to be like of unknown or possibly relatedness to Trikafta. So not all of these ones were deemed to be related to Trikafta use. Of the 3 infants that had some kind of mild congenital malformations out of that group, 2 of them were born to moms who had uncontrolled diabetes, and so we know that that's a risk factor for this complication as well. And then Nash and colleagues also published a case series in 2020 that described 44 pregnancies in patients who were exposed to modulator therapy at some point in pregnancy. These were not all Trikafta at all. They were mostly ivacaftor alone. And although no infant complications were found, interestingly, they did find 9 complications in moms who stopped their modulator, right? So we would expect that. We would expect that moms who stop modulators would have some sort of decline in their FEV1, maybe have more exacerbations, and that's exactly what they found. And then some more real world evidence kind of coming up to 2022 now. We've got a case series by Kendall and colleagues that looked at 5 pregnancies. 1 patient did get some transient transaminitis, which we know happens with modulators anyways, so probably wasn't anything specifically related to pregnancy and Trikafta use, but no infant complications. Similar story for Fortner, but no mother complications. A very interesting case with a lot of benefits in that article. And then, lastly, we've got our case series of a pregnancy that you're going to hear more about from Kim Foyle, so stay tuned for that. But again, just mounting evidence that use of modulators in pregnancy is seemingly safe and effective, but again, we don't know everything, right? So we need more, and we'll talk about what's coming up. Lactation now. So like we did for pregnancy, let's start with the animal reproductive models here. Again, these are all individual components that we're looking at in lactation. We know that they all are excreted into the breast milk. We don't know the significance necessarily of that amount, but we do know that cataracts were observed in juvenile animals when exposed to ivacaftor regardless of the dose. And so we have to keep that in mind. All of our components, or all of our compounds have ivacaftor in some way. So we have to be mindful that they did observe cataracts in juvenile animal models. They did not find them in adult animal models. And there is a way that we can monitor for that. All right, real world evidence. Well, it's really sparse, really sparse, maybe even more so than pregnancy. And a lot of these, you'll see, these are similar surveys and case series from things we've already looked at. So Dr. Taylor-Kauser and Nash looked at a subset of patients who continued modulator use during lactation after that pregnancy period. They found no adverse effects in the infant, which was great, after being exposed to a modulator during lactation. There was a case report by Maines and colleagues that found no adverse effects as well, but then interestingly, look at this last one here. Trimble and colleagues had a case report of one infant that was exposed to Orkambi during lactation. The infant did have elevated liver enzymes in the first month of life, and so the team worked with the mom to come up with a plan of how to reduce breast milk exposures of the medication through breast milk. So what they did is they supplemented formulas for 75% and breast milk down to 25%, and they found that this was effective. So a week later, the elevation in the liver enzymes went down, and so they were able to continue on. All right, so I do want to get a little pharmacist nerdy this morning, so I hope you guys are all ready for that. I want to talk about why, right? Like, why would we see this happening in infants? Could they have this elevated liver transaminitis, or is it just a coincidence or what? So I wanted to see what the mechanism behind that might be. Well, so this may be part of the answer. So infants are born without a mature intestinal cytochrome P450 enzyme system. I'll just call it the CYP3A4 system. This is the major metabolism pathway for our components of our medication, so ivacaftor, tezacaftor, elexacaftor, right? So we need this system in order to metabolize these components. But unfortunately, this system isn't fully developed for the first 2 years of life. So our infants really don't have a way to metabolize those components very well, and that may be why we're seeing that. So to demonstrate that a little bit better, if we expose a baby to a medication that requires the CYP3A4 to metabolize it, and the system is not fully functional, this could increase levels of the modulator in the blood, and maybe that could increase the risk of adverse effects. So I do think it is really important, right? And even though the small amount of data that we have maybe seems positive, which I would take that as kind of my summary, it's important to consider monitoring, really important. So what do we do about that? Well, I've asked. So I did a bunch of literature searches. I've hit up the listservs trying to see what all the different centers across the US are doing about this, and it's totally varied. So some people are monitoring for this liver function abnormality in infants, and some are looking at cataracts in infants, but some are not doing that, right? And so there's just so much variation that I would hope today we can kind of talk about maybe a way that you can take this back home to your center. So I know that it's not easy, right? Like, we're making recommendations based on things that we don't have a lot of evidence about. There are a lot of considerations that go into this discussion, like, is the mom going to be breastfeeding for a long time? Who will follow up on results if we order these cataract testing or liver function testing? Like, will the pediatrician do it? Will we do it? Again, I think that's where you guys are all in this really unique spot to be able to facilitate that communication. And I created a center-specific handout that I give to every patient. And so the patient can actually take this handout to their pediatrician, and it says why this topic matters. It tells them the studies behind why we care about monitoring for cataracts and liver function in our infants. And then it also links them back to me. So it gives them ways to contact me. I have my direct line on there, and I've had success with this. So I do have pediatricians who call me when infants are born to mothers on modulators in Idaho. And it's been really successful. So I wanted to just kind of pop it up here, but please email me and I will send you a copy because I think we should all share. And then really quickly, a lot of people ask me, well, what do I do if a patient has a high liver function test and they're an infant? Like, what am I supposed to do about that with the infant? Because I want my patient to be able to continue their modulator. Well, basically what this breaks down to is that if you think it is really modulator related, there are ways you can kind of play with that breast milk split. So you can split breast milk and formula. Again, this is a very personal decision, and moms have very strong opinions about this, rightfully so. And so having that discussion with them is really, really important, but that is one way that we found success. And then in the future, right, what do we have to look forward to? Mayflowers. And this is Dr. Taylor Kauser and colleagues, and you will hear much more about that this conference. So I'm really, really excited for those outcomes. So in summary, pregnancy in women with cystic fibrosis continues to rise because of our amazing modulators, but we have to know how to deal with that. So we need to know how to monitor for safety in these patients. So cataract monitoring, liver function monitoring, and again, this decision to continue a modulator is not an easy one, but you guys can all have these discussions with patients and help them decide what's best for them. Thank you.
Thank you so much, Sabrina. And we do have time for one or two questions. And I don't see any that have been posted on our online system, but if anybody has any in-person questions, and you know what, is there a handheld mic that we ever got? No.
I think
I can repeat back.
Sorry.
Great. Okay.
So my question is, how are you getting your handouts to the pediatrician? Like, how are you making sure that happens?
Yeah, that's a great question. It's an issue that we run into, obviously, but what I really try to do is stress the importance to the patient. Right now, I don't have a way to know whose pediatrician will belong to everyone. We have a lot of patients who live on all sides of Idaho, so I won't have a really close connection with all of them, but I give the handout directly to the patient, and that seems to work most of the time. Yeah. Yes.
I have a tangential question. Do you know any data on CYP3A4 polymorphisms and high expression or how that affects
Yeah.
dosing? I
Yeah.
know there's not modifications, but where do you find it?
Yeah, so the question was about CYP3A4 polymorphisms and how that can impact these modulators. I don't know the answer to that. It's been a big topic of discussion though, and we see that in our patients all the time. We see patients who only really need like one orange tablet a day and seem to do just fine clinically, and if you try to increase it more, they get really significant liver enzyme elevation. So we see it. We haven't been able to categorize it yet, but there was a poster, I think, this year that kind of looked at individual differences between modulator dosing and to kind of answer that question. But yeah, it's a great one. Yes, of course.
Any other questions right now? Otherwise, we will have time at the end. But I do have one question. So this is probably a pharmacy naive question, but are there any changes that happen in metabolism in pregnancy?
Yeah, great question. So in regards to metabolism in pregnancy, yes, there are absolutely changes in pregnancy that can impact the way that medications work. We see that all the time with antibiotics, and it's probably the same with our modulators. It just hasn't been well categorized. The Mayflower study is going to look at pharmacokinetics, and so of the mother and the infant, and so I think that will help answer that question, hopefully.
Thank you so much.
Of course.
And now we would like to ask Kim Foyle to this podium, please. And we're very excited to hear about this case study.
Good morning. Thank you all for having me. I have no disclosures related to this presentation.
Want to use either the arrow or click?
There we go. Okay. So today I'll be starting with a review of our published case report regarding CFTR modulator administration via an unaffected carrier mother to treat meconium ileus in a known affected delta F508 homozygous fetus. So I'll talk us through the case to the time of publication first, and then give some updates since we published the case, because we have a few more months of data on this baby now, and build on what Sabrina talked to us about regarding the maternal fetal risks, benefits, and unknowns of modulator treatment, with a focus on potential in utero treatment of cystic fibrosis disease. I think the astounding things that modulators have done for our patients with CF in terms of disease treatment have really opened windows into questions of whether CF disease can be reversed or even prevented with very early modulator use. And this brings up a lot of ethical questions because there are so many unknowns, and we have an excited patient community and clinician and researcher community, but what should we be doing along the lines of what we can be doing? So we'll talk about the ethical considerations as well. Jumping into our case, we had a 34-year-old mother in her second pregnancy in general good health. And she was known to our team because her first child has cystic fibrosis and was age 3 at the time, a homozygote with both parents confirmed to be carriers of delta F508. Now, amniocentesis is the diagnostic prenatal test that can tell us for sure whether a fetus is affected with cystic fibrosis before birth. And I'll give a quick mention to the fact that there are now non-invasive methods that are pretty accurate to screen for cystic fibrosis, and we may see larger uptake on more advanced prenatal testing if there's really something we can do about it before the baby is born. In this case, the mom was motivated to find out whether this fetus she was carrying was affected with cystic fibrosis and opted for that amniocentesis, which confirmed the homozygous genotype in a female fetus. At the time of amniocentesis, the fetal anatomic survey was normal, but follow-up anatomy scan at 23 weeks gestation revealed a dilated bowel. Care was transferred from the primary OB to a maternal fetal medicine physician closer to where the patient lived, who found that the fetal bowel was consistent with meconium ileus, and transferred care to our academic medical center and the maternal fetal medicine team affiliated with the Medical University of South Carolina. The patient began seeing our medical center at 28 weeks and through the duration of the pregnancy, knowing that with meconium ileus, she'd need to deliver at MUSC for access to our NICU. And this is also where her daughter receives her CF care. So the CF team knew the patient very well on the pediatric side. And as a genetic counselor, I have actually worked with our maternal fetal medicine team extensively in the past and worked with both our pediatric and adult care teams and knew the patient pretty well going into the consideration of dosing for potential fetal treatment. The mother approached the CF team. She approached me and the physicians with the question of could we get her Trikafta to treat her baby with CF. And we want to be equitable in terms of treatment of the CF population at large, of course, but I think that was something that did impact the way that this was approached with her, is that we knew her and she brought it to us. So we knew this wasn't someone who was going to take the drug and disappear and never return to care, and we knew that it was somebody who was intimately familiar with cystic fibrosis and modulators, as her 3-year-old daughter was on or can be and had been for a bit of time at that point. So mom was very motivated to take Trikafta herself for potential fetal benefit, knowing from her own research and talking with us that it does cross the placenta, that our adult team had experience with a number of adult patients who stayed on modulators for their own health during pregnancy with no apparent adverse fetal outcomes. But of course, there are many unknowns, and we were all a little bit trepidatious of should we really embark on this path with the mom. And we embarked on a shared decision-making process that extensively involved the mother and father, the pediatric and adult CF care teams, several maternal fetal medicine specialists, and neonatologists. And over the course of several visits, We reviewed all available literature. Most of the studies that Sabrina talked about, we went through sort of a one-by-one with the patient so that they had a good understanding of what's known and also what is not known, and that there can be potential unknown risks, especially when we're thinking about delicate populations such as the fetus and the pregnant woman. We discussed the limited and incomplete human data and what it means to use a drug off-label. We talked about the known side effects of Trikafta, but that Trikafta has not been studied in pregnant cohorts specifically or non-CF cohorts like a carrier mother, where we know that a pregnant woman who has CF herself could reasonably sustain benefit from the drug. This would solely be with intent for fetal treatment. We talked about potential infant risk, including cataracts, transaminitis, and potentially other unknown risks, as well as the loss of modulator access from the time period between birth and or breastfeeding to FDA-approved dosing for that child, knowing that there can be risks related to modulator withdrawal, and potentially even if we could preserve, say, pancreatic function to birth, if we lose modulator access once that child's not connected to the mother who's being dosed, we don't know exactly what's going to happen to that infant, and it might not be a good thing. After very careful counseling from the multidisciplinary team, the patient definitively wanted to try drug, and we decided to proceed with Trikafta dosing of the mother at standard adult dosing following normal start precautions, including baseline maternal liver function testing, which was normal. She started the drug at 32 weeks gestation, and the pregnancy was followed closely from that point to the birth of the infant. At day 13 of drug, or 33 weeks and 5 days, the fetal bowel lumen appeared essentially unchanged, so it was still dilated, hyperechoic, and consistent with meconium ileus. However, on day 27 of drug, the bowel findings had resolved, and the amniotic fluid had a turbulent appearance that the maternal fetal medicine team said could represent meconium that had been passed in utero, or could represent a maternal uterine bleed, vernix, or a nonspecific finding. So this slide walks us through the prenatal ultrasound findings and the dosing of drug, where we initially had a normal fetal ultrasound at 18 weeks. 23 weeks we had findings that were suspicious of meconium ileus. With transfer to maternal fetal medicine, we had many MFMIs who all agreed that this was consistent with MI, which of course occurs in about 20% of fetuses with CF and should be considered anytime there's bowel dilation or echogenic bowel on fetal ultrasound, and then those findings interpreted in the context of whether the parents are carriers for CF. In our case, we already knew that the infant did have CF, so it was a pretty clear call. And this is not a finding that you expect fetal resolution of in the natural history of the finding. So we dosed starting at 32 weeks, no change in the first 2 weeks, but 4 weeks later, the bowel findings had resolved. Spontaneous labor and vaginal delivery occurred just 2 days after that ultrasound with resolution. There had been a planned C-section in this pregnancy based on her birth history with her first pregnancy, but she didn't make it that far. She went into spontaneous labor at 36 weeks and 1 day, and a female infant was born weighing 5 pounds and half an ounce, and APGARs were 9 and 9 at 1 and 5 minutes. The amniotic fluid was meconium stained, and the baby was admitted to the NICU solely based on the prenatal findings. There were no infantile concerns, but we wanted to complete the bowel status evaluation based on the fetal ultrasound findings of likely meconium ileus, and knowing that we had dosed and tried to treat and resolve that. The abdominal x-rays were normal without signs of obstruction, and breastfeeding was initiated. Enzymes were also initiated, knowing that most infants with the delta F508 homozygous genotype are pancreatic insufficient and will require enzyme replacement therapy. The baby passed meconium at birth with multiple stools on the first day of life and was discharged home feeding and stooling normally on day 2 of life. Infantile bilirubin was normal. And we saw the baby back on day 13 of life, at which time labs were drawn and normal, and we saw the baby again on day 27 of life and performed a sweat test at that time. The sweat test for this child was 64 and 62, which is consistent with cystic fibrosis and abnormal, but significantly lower values than we would expect for a homozygote in ordinary circumstances. The mother did continue the Trikafta while breastfeeding, knowing that it's excreted in breast milk and with the intent of continued dosing of the infant since it was being well tolerated by the mother. The newborn screen did have elevated IRT consistent with an abnormal newborn screen for cystic fibrosis, but again, we already knew that this infant was affected and they were already plugged in with our CF team. I have a graph here of the baby's fecal elastase, where a stool elastase was performed on a meconium sample while the baby was in the hospital on day 1 of life. And we had already started enzyme therapy presumptively, and it takes a few days to get those results back. Those results came back at 95, or not consistent with pancreatic sufficiency, but we learned that all babies have pancreatic insufficiency in a meconium sample. A case series of 77 infants without cystic fibrosis all had low pancreatic elastase in meconium stool, where it returns to sufficient or normal levels by days 3 to 4 for full-term infants and by 2 weeks of life for preterm infants. So consistent with that, when we checked the fecal elastase of this infant at 13 days of life, she was pancreatic sufficient, and that has persisted since we've been able to maintain pancreatic function for her. An eye exam was also recommended because of the risk for infantile cataracts, and mom completed that at about 4 months of age with normal findings. And through the time of our case publication, mother continued to breastfeed with the drug well tolerated on the maternal side and great effects for the fetus in terms of resolution of the MI. So with resolution of meconium ileus, we were able to avoid likely surgery and other interventions, as well as related costs, length of stay, caregiver stress, and associated worse CF outcomes in babies with MI as compared to CF counterparts. The fecal elastase levels do remain consistent with pancreatic sufficient status, and her growth trajectory has been excellent. This case highlights the potential for disease reversal or prevention. I'll show you some of her growth curves and a little bit more data, but wanted to give some updates between when we published the case at the baby's age of 4 months and current, as the baby actually just turned 1 a couple weeks ago. So mom continued her Trikafta and breastfed to age 4 months, and very soon after our publication, mom actually had transaminitis with elevated ALT and AST that was possibly related. So we asked her to stop taking Trikafta following our standard protocol in that situation, and trended her labs, which they did not come down as quickly as we expect for transaminitis that is definitively related to modulator use. And mom was also taking some supplements related to her lactation, some herbal products, had restarted a medication for her headaches that she had been off of during pregnancy. So we really don't know if this was modulator related or not. We were prepared to potentially re-challenge mom if her labs normalized, and that was the best course, but we were sort of scrambling to explore all possible avenues at this time. And mom had been rigorously pumping and storing and freezing breast milk for the day when natural breastfeeding might end. So she was able to use her freezer supply to continue giving baby previously frozen milk that had Trikafta in it, which of course raises a good question of can you freeze and thaw and still maintain the effectiveness of the compounds. But in this case, apparently no harm was done. We also started looking at early access to a modulator for the infant in terms of direct dosing, and we're able to get an Orkambi prescription approved for the baby at age 4.5 months. So still early. Now it's approved down to age 1. At the time, it was approved only to age 2. But fortunately, this family's insurance plan was really easy to work with, I think maybe in part because there was the 3-year-old already receiving Orkambi in the family. And so they were aware of cystic fibrosis and modulators from that prior experience. But we started the baby on Orkambi at 4.5 months, and we all had that question of, is Orkambi going to be good enough compared to Trikafta, even though baby's not getting a full Trikafta dose sort of secondhand from mom, but good enough to maintain pancreatic function? And the answer has sort of been yes. Mom has wanted to obsessively check the stool elastase, and I don't blame her, but our data points are all here with the red line at 200. Demonstrating the threshold for pancreatic sufficient versus insufficient. And our only points below the sufficient mark are that meconium stool, which is to be expected, and a stool that was poor quality. It was a liquid stool, and the lab said that it didn't meet quality standards, but did give us a value. But the baby has maintained pancreatic sufficiency to age 1 and continues on Orkambi. And here are her growth charts in terms of length, weight, and weight for length. I show the adjusted growth chart because she was 4 weeks early, so our open circles are the gestational age adjusted points. But we can see she's at about the 70th percentile for her growth, which is really wonderful for a baby who's homozygous for Delta F508. So ethical considerations, we exposed the mother to a drug that is not thought to have any physiologic benefit to her and could potentially have risk of transaminitis or other complications that we see in our CF patients who are starting modulators. And although we are gaining experience with pregnant women with CF, this is not a medication that has been extensively studied in pregnancy or in people who don't have CFTR dysfunction that we really need to hit and correct. So parents are willing to go to great lengths for their children. We wanted to take an objective approach and make sure that we were presenting an unbiased portfolio of the risk, benefits, and unknowns to the mom to enable that decision-making in a shared decision-making process where the patient is the most important voice at the table, but we have a balanced team of experts making sure we're not incurring undue risk. The cost of the drug was another consideration. As we all know, it's an expensive medication, but we did feel that it was for a short period of time, and this child was going to have lifelong cystic fibrosis, and if there was a chance we could improve the neonatal course extensively and improve long-term CF outcomes, it was worth it if that's what the patient wanted to do. We researched the natural history of meconium ileus extensively, and there's a likely prolonged NICU stay with an average stay in the NICU of about 27 days for MI, with each day in the NICU being very costly, and that stay alone exceeding the price of the Trikafta for the brief period of time mom was on it. Plus infant surgery, infant suffering, the psychological hardship for the family, seeing your child endure that, potential loss of work, traveling to be closer to the center of treatment since they don't live right around the corner from us, and worse long-term outcomes where people with meconium ileus do have more medical issues down the road and higher cost of stay for each CF hospitalization as compared to non-MI counterparts. As I mentioned before, we considered the loss of modulator access, but ultimately, between the patient and the team, we decided that this would be considered a success if we could simply prevent the surgical consequences of MI at birth, and then we'd kind of deal with the rest. I think we got the best case scenario where we were able to maintain access and there were no real adverse effects, and the child is thriving and is doing so wonderfully. But we did have to consider that it might not have turned out quite so well. So in summary, this highlights the potential for disease prevention or reversal via very early modulator access, even potentially dosing an unaffected mother who's known to be carrying an affected fetus. In our case, contributes to the growing but still incomplete body of knowledge and many questions remain about large-scale safety, efficacy, and timing of treatment. And it's really critical that we gather more data to approach this in an evidence-driven manner. And I'm excited to see what the Mayflower study holds for us. And there are several other case reports being presented at this conference that collectively can guide us in the future. Thank you. Acknowledgement especially to the patient and family who allowed us to work with them.
Thank you so much, Kim, for an excellent presentation that is amazing outcomes and very thought-provoking. And we do have time for a couple of questions. We have 2 questions on our app here. And the first question comes from Aaron Wilson. How are you able to gain access to Trikafta in the carrier mother?
Yeah, great question. How are we able to gain access to Trikafta for the carrier mother? So we thought about several channels when this came up. Could we ask the drug company to provide drug? Should we go through our research board and do an N-of-1 study? Ultimately, after exploring some of those avenues, the prescription for off-label use was the way that was most seamless. And we had our adult pulmonologist caring for the carrier mother, since our adult team is familiar with adult pulmonology as well as modulators. So it was a prescription that was written and submitted to insurance, and we were just very fortunate that this patient's insurance company picked it up. I can't say whether they did or did not know exactly what they were covering. The 3 questions that sort of come up are, does the patient have at least 1 copy of Delta F508? And this carrier mother does. And is the drug being used to treat cystic fibrosis? And it was. And is the drug prescribed by a pulmonologist? And it was. And there were no more questions. They approved it and shipped it to her very quickly. And same with the infantile approval for Orkambi at 4.5 months. I don't think that all insurance companies would so easily get behind either of those scripts. But in this particular case, the questions were minimal and it was very smooth and everybody counted their blessings. So.
It's amazing. And thank you. And there's one more question, but I think it's been answered because it's a very related question to the first one. The first question was Trikafta, which was used by the mom, was it reimbursed by health insurance? So you had addressed that.
Yeah, it was fully covered for them. So they incurred no costs. I learned many interesting things during this case experience, including that there's a black market, if you will, that patients who are very motivated can get drug on their own accord. So we would rather be able to supervise and make sure it's done responsibly. We've had some Trikafta returns to the program, say from deceased patients or patients who no longer need it. So we considered a research proposal on whether we could use it in that capacity, but our IRB had some concerns mainly around the fact that we couldn't guarantee proper storage of the drug at proper temperatures since we hadn't been in possession since it was dispensed. So we wanted to do this in the most above board fashion, and that turned out to be through insurance in this particular case. I would love to see a study that is really done above board and addresses this in a larger objective fashion, but for her it worked out.
I have about 100 questions, but I'll just ask one. Was the Delta homozygous remaining pancreatic sufficient, like just a side bonus, or was that something that was anticipated?
So good question about the sustained pancreatic function. It has been demonstrated in animal models. There are ferret models of G551D homozygous kits treated with ivacaftor in utero where pancreatic function is sustained, and with continued treatment after birth, it's maintained as long as treatment continues. So it's plausible, but it's a really novel area. So if we did this 100 times, what portion would have sustained pancreatic function? I don't know. I don't think we can say. There's another very interesting case that we reference and somewhat discuss in our written case report in the Journal of CF. If you have time and want more information, we dive into Dr. Chris Fortner's case, which just predated ours by a little bit, where an infant with CF was born to a mother with CF, and the mother with CF had maintained her modulator treatment, and that infant was actually missed by newborn screening, so IRT in the normal range and pancreatic sufficient. It's not my case, but I believe they ran into access issues with the modulator and had some pancreatic trouble accordingly. So if that answers your question, I think there are just a ton of unknowns, but it's plausible and hopeful that pancreatic function could be I'd say rescued, but maybe pancreatic sufficiency even prevented if modulator treatment was started early enough. And there are questions about the male reproductive tract as well, and also ferret models that show with early modulator treatment, you can prevent absence of the vas deferens in males. We've had some patients with risk for CF kind of reach out over the last year with interest in starting a modulator at like 6 weeks or something when they get that positive pregnancy test, and what are you supposed to do for the community? And I think the answer is we don't know. We haven't jumped on board with treating anyone else. We're not like opening our doors for everyone in the country to come for this treatment, but people are very interested if it's tolerable by the mother and can potentially prevent sequelae for the fetus. That's of course very exciting, but we want to do it in an ethically sound, evidence-driven manner.
Thank you so much, and I'm sure there's a lot more questions. There have been a few that are posted, and I'm sure the rest of you have some too, but we will wait for those questions at the end, and thank you for this excellent presentation. We'd like to invite Tina Koshari, please, to come to the podium for the next presentation.
Thank you for being here this early in the morning, especially if you were like me and up a little late watching the World Series. Go Phillies. But I'm really excited to be here today to talk about genetic counseling intervention I did during my time at Emory. So today I'll be speaking about preconception genetic counseling considerations for adults with cystic fibrosis, a new era. And I am currently a senior GC practicing reproductive medicine in New York City, so still very relevant in my work today, and it's really been great to see advances of this. I have nothing to disclose. So, as we all know, historically, persons with CF face numerous obstacles to family planning, with the two biggest ones in relation to preconception counseling were reduced lifespan and CBAVD, and then also just indirect and direct effects of the CFTR mutation. But now we're kind of in a new ballgame. Advances in assisted reproductive technologies, or ARTs, as I'll be saying the rest of this talk, and the development of our modular therapies are completely changing the landscape of CF care, not just via medication treatment. So just a really quick overview on ARTs and CF. So historically, most men with CF are considered infertile due to CBAVD. However, we know that most men with CF have healthy sperm production. It's just a matter of the vas deferens being blocked. So today, pretty easily, surgical sperm collection, it can be done combined with intracytoplasmic sperm injection or IVF for a couple to have a biological child. So for IVF, as we all know, sperm and egg combined outside of a woman's body and then implanted back in. ICSI, the sperm injection is a specialized form of IVF where sperm is directly injected into an egg as opposed to kind of just letting them go in the petri dish. So you can see the difference on the left side there of what the two procedures would look like. The ICSI is used very often in many cases, but historically has been said when there's male infertility involved. And then where we come in as genetic counselors is really this option of pre-implantation genetic testing. So prior to implantation, couples may choose to undergo genetic testing for the embryo. And there are 3 types of different PGTs now. So the first one is for abnormal chromosome number. This is kind of the most basic that most people kind of just go do it just for kind of thoroughness. But what I think is most interesting and relevant today is this PGT-M, so known monogenic disease. So if we have a couple that if one individual is affected with CF and we know that their partner also is a carrier, we can go and screen for these embryos before implantation. So genetic counseling in cystic fibrosis. So historically, children with CF and their families receive genetic counseling once at the time of diagnosis. And at that time, the time of diagnosis is a very difficult time. Many families are not able to absorb many aspects of the condition, especially in adult years, rightfully so. And then, we're adding this new layer of ARTs and family building, and these can be so sensitive and deeply personal for patients. So it adds another layer of complexity when counseling. And we do know from research that there is a known knowledge gap in patients with CF regarding the genetics of the condition and fertility implications, which our study showed as well, so I'll go over those results. So what we did is our study aimed to measure if and how a genetic counseling intervention may influence knowledge and or perceptions about genetics, fertility, ART treatments, and family building options among adults with CF. Here we have our study design. So we recruited males and females over the age of 18, treated at the adult CF clinic at Emory University in Atlanta, Georgia. We used pre and post intervention surveys to measure changes in knowledge and perception. So essentially we gave a survey 3 times, before the intervention, immediately after, and then 3 months after to see what the retention rate was. Perception questions depended on the participant's family building preference, and what I mean by that was, at that time, do they desire to have children? Do they desire not to have children? Or do they already have children? And I'll go more into that and talk about the types of questions. And in order to reduce variability, we did use an outline for genetic counseling about the information provided. So everyone, as much as we could control for, got the same information. So briefly, like I was talking before, we had survey 1, which is before the intervention. Then we had the intervention, which was done by me. Survey 2 was immediately post-intervention. And then we had a survey 4 to 12 weeks post-intervention. Just to talk a little bit about the survey. So we started with demographics. This was only asked on survey 1. There were 21 knowledge questions. This was a combination of multiple choice and true and false. Then we had questions about their confidence in explaining ARTs. These were self-reported on how they felt. These were done by a Likert scale, and the range was from no confidence to very confident. And then finally, we asked their family building preference, and this was their branching logic question. So based on how they answered this question, they got one other subset of questions. And so this was based on wanted children in the future, has children, and does not want children in the future. This was a combination of Likert scale questions, multiple choice, and there was actually one rank question where we asked them, what kind of rank what would be most important to you in terms of, building a family. Here is just an example of some of the survey questions. This is specifically for the subset of people that desired that they wanted to have children. So they would this was the paper version. We did administrate it via an iPad, but we always had a paper one, so this is what that would look like. So the genetic counseling intervention itself, we talked about the genetics of CF, of course. the mutation spectrum, inheritance pattern, carrier frequencies, carrier implications, fertility issues in CF, so CBAVD, and also for females with abnormal cervical mucus secretions, family building options. So we went through kind of all the other options, so not only just IVF and genetic testing, we talked about donor egg, donor sperm, surrogacy, and adoption as well. And I do want to mention, I think it was on one of my slides, when we were actually recruiting and collecting, it was actually before TRICAFTA, it was right before. So I will talk about at the end of this how I think all of this changes and it actually improves the need for genetic counseling in this population, but just to keep in mind, this was collected in like 2019, so right before. So these are the counseling aids I used when I was counseling these patients. I really liked this one in terms of talking about the different CFTR mutations, especially in the context of modular therapies, and also just how inheritance looks different when a parent has CF, right? And then we talked about IVF, things like that as well. So I want to go through the results, and then we'll go into a discussion about what we think about these results and next steps. This here is just a brief overview of our participant characteristics. We had a total of 35 individuals who underwent the intervention. We enrolled 35 out of the 48 potential subjects that I approached, which gave us a rate of 72.9, pretty equal in terms of gender. Education, relationship status, and preference were kind of mixed, although majority did indicate they wanted a family. Just some things to highlight. 20 participants had never discussed fertility options with the provider. This was very consistent with some of the data some of the literature review I had done before. 22 participants had never discussed fertility options with a genetic counselor. And of those who had discussed fertility with a provider, most had spoken with their pulmonologist who managed their CF. So when we're looking at those 21 knowledge questions, this is just a graph of showing how the average percent correct. So pre to post intervention, we saw a large spike. That's pretty expected, just gave someone a lot of information, they remember the answers, and their score went up. What I was really interested was between points 2 and 3 on what we can retain and how much is retained. And we did see a little bit of a dip. These were significant differences between 1 and 2 and 2 and 3 with a p-value of less than 0.05, and we just used a one-way kind of ANOVA to look at this and how demographics actually affected this score. So the one-way ANOVA showed us that participants who were married had a higher baseline knowledge compared to those in a relationship or single. So, they were thinking about it, maybe they're researching it. And participants with a bachelor degree had a higher baseline score compared to those with a high school education or below. I want to talk through some of the common questions that they answered correctly and incorrectly. So the most common correct questions were the cause of cystic fibrosis, which is essentially their understanding of autosomal recessive inheritance. And then the other one was chance of having an affected child, kind of the same realm, autosomal recessive. They were able to answer correctly that they had a 1 in 4 chance of having a child, that 2 carriers had a chance of 1 in 4, not them themselves, just in general of autosomal recessive inheritance. That's really important because for commonly incorrect questions, chance of having a biological child to be a carrier for CF, given the participant has CF, was 100% chance, and only 31% had that correct. There were 2 questions regarding assisted reproductive technology, one about IVF and one about PGTM. 47% answered one of these correctly, while 23% answered both incorrectly. So we are seeing some knowledge gaps here that we wanted to mend through our intervention. Going towards the self-reported changes of confidence in explaining fertility options. So this is a little bit of a busy slide, but basically the top number is the number of individuals that increased in confidence, no change or decreased, and then below it is just the percentage. So we did see some increase. We saw a lot of no change as well, specifically in IVF, and that's I think that was a little expected because a lot of people did know IVF as opposed to like IUI or PGTM and donor egg, donor sperm. What I think is really interesting is this decreased confidence. So this was immediately after I had given them all this information and their confidence decreased. So, you know, what happened, right? Were they feeling really overwhelmed with all the information that they were giving? Was it not their type of learning? Did, you know, the modality of learning? Were they not paying attention and they just wanted to get out of here? That too, very possible. So it's just something to think about in terms of, you know, why this is happening. So participants, perceptions of participants who desire children. So I'll go through kind of those three different preferences and see and show what we found in those three different categories. So 24 participants had said that they desired children. Majority indicated that they felt that their health would not allow them to care for a child and that their health would decline. In the next slide, I'm going to show you which family building options they would utilize versus not utilize. And in this section, we asked them which factors were the most and least important to them when making these family building decisions. The risk of any of the IVF or ART treatments plus success rate were the most important to them, and religious beliefs were the least important. So here we have a graph where we break down the, So each type of family building is on the left. The blue means they're likely to use it. The purple is they're unsure if they would use it. And the green is that they're unlikely to use it. So for example, for the adoption, majority of people said that they would likely utilize adoption when building their family. So with that, adoption was utilized the most, followed by IVF, and then also with PGD. Most indicated they would not use donor sperm or egg. Majority indicated, when this was a separate question, but it was majority indicated that they would find some sort of way to have children if they were unable to naturally. So this is important to our patients. They want to build a family. And again, this is before Trikafta. So now, I think that desire, as everyone said today, is even higher. And looking at these family building preferences, we do ask them this in every survey, and we actually didn't really see a change given the knowledge that was given post and post-post. Where we did see some changes is 4 participants were more likely to use IVF or IVF with PGT. 1 was less likely to use donor egg. 1 was more likely to use one was less likely to use donor sperm. 1 was more likely to use donor egg. And 3 were less likely to utilize surrogacy. So these are just kind of points that we found. I find these really interesting, and you know, since this was a quantitative study, one of the things I'll talk about is doing a qualitative study on this would be really interesting because I'm very curious as to why they answered this way. But that's kind of the data points that we saw here. If we were going to the participants who already had children, this was a really small number of the patients that we recruited. It was an N of 3. None were actively trying to conceive. Only 1 had been referred to genetic counseling, which to me is a little alarming. But 2 of 3 underwent carrier testing for their partner. All of them declined invasive testing while pregnant. All women felt that they were currently healthy enough to care for their child, but 2 of 3 worried that they might decline in the future. And there were no changes in these perceptions following genetic counseling intervention, which was not expected. And finally, we go to the participants who did not want children. And so this was an N of 8. 5 of 8 did not feel healthy enough to care for a child. Most disagreed that having a child would make their health deteriorate. So they more so felt at that moment that they weren't healthy enough. Half the participants indicated they did not want to have children because they did not want their child to have CF. And all indicated that there were other personal reasons of why they did not want children. Again, a great avenue for a qualitative study. So just going into our conclusions and what I think maybe some next steps could be. Consistent with previous data, many do not discuss fertility options with providers, but they do still desire children. There is really similar data regarding family building in other genetic patient populations, such as carriers of BRCA1 or 2 and sickle cell anemia. And what we kind of thought about in terms of genetic counseling in this aspect is there's definitely a benefit to genetic counseling. However, we're seeing that knowledge may not be fully retained from just one session. Multiple conversations regarding fertility options are needed, and also more importantly, at the appropriate time. So the way this study was done, we were just approaching the adult patients that were on the schedule. I think something that's very helpful is when a patient themselves is ready, right? It's a big topic, it's a personal topic. And I think it's really important to incorporate these conversations into the multidisciplinary CF clinic, because that's where these patients go for their care, and they don't, tend to go anywhere else. They like their pulmonologist, they go there, they see everyone, and at least that's how Emory is situated. So I think it's really, really important to incorporate these conversations in that clinic itself. Some interesting things that we saw. So interestingly, 4 of 8 participants noted that they did not want children because they were afraid their child would have CF. Even after the intervention where it was stated his or her future children were only at risk if the partner was also a carrier, this perception of fear did not change. They still feared of having a child with CF. So kind of as I was alluding to before, the introduction of modular therapy will likely drastically change patients' perceptions of parenthood and family building, and we already see the data there, that it is changing, and it's probably going to change even more. So this reiterates the need for genetic counseling in adulthood. In addition to studies regarding this effect on physical reproductive health, I also think mental health is just as crucially important, so that should also be something that we look at. The combination of modular therapy on physical reproductive health, which I know we've talked about a little bit today, and mental health, I think gives us the best care for our patients and being able to give them the resources they need for family building. So some limitations and further studies. This was a small convenient sample from one academic center. Parenting intention was asked in a dichotomous way when in fact it's very complex an answer. We asked, do you want children, do you not want children, or do you have children? There's a lot of in-betweens there. But in order to get the data, that's kind of what we landed at. Further studies, we would love to do a larger sample size at multiple sites, or even kind of gain knowledge from other sites on how they're doing this and what works for them and what doesn't work for them, and explore different methods of knowledge retention. I think that's huge, right? We saw that dip, and I want to figure out a way to retain that knowledge. And qualitative studies on other things, except for, these aspects of genetics of CF that are maybe that we didn't ask about, that are influencing their family building preferences. And finally, just some acknowledgement. So my mentor while I was at Emory, Dr. Randy Hunt, who was amazing throughout this process, my co-authors, and all of the adult CF program team at Emory University, which I'm very thankful for. They always made time for me to try to peek in and do genetic counseling, and especially the Emory Genetic Counseling Training Program, which is how I even found this project, and then my funding, and we also had some stat consultants. And these are my references, and I'm happy to take questions.
Thank you. Thank you so much, Tina. And we do have one question that was posted, and we will probably only have time for one question at this time, and then we will ask for more questions after. And so the question comes from Rebecca Cole. And how do you view the low percentage of patients who correctly answered the question regarding carrier status of children of a CF patient with the majority of positive attitudes towards adoption? So you want me to...
I think I have that correct.
Okay.
So comparing the amount of patients who incorrectly answered the carrier chance and then combined with adoption. Is that why they would utilize adoption? Do I have that right? Yeah? Yeah?
I have a question.
Okay. No, thank you.
I was just curious, so it seems like the majority of your patient surveys thought positively about adoption
Yeah.
as a means of building your own family.
Yeah.
And yet it seems like there was a huge knowledge gap.
Yeah.
In carrier status for
Yeah.
their children. And I guess I would assume that the positive attitudes towards adoption would be influenced by the knowledge that all of their children would at least be CF carriers.
Yeah.
But it seems like
No, absolutely. We had talked about that a little bit on how that probably does influence it, and we didn't really do any like qualitative, and I think that's where this would be important. Like, is that really why you thought that? But yeah, that's a really good point.
Especially because your population, it seemed like there were slightly more males than females. And
Yeah.
I would consider like pregnancy risks to be another
Exactly.
rationale for going the adoption route, if not for carrier status, but there were more males than females.
Yeah, no, definitely. It's definitely an interesting combination and trying to figure out the reasons why.
Thank you so much for an excellent presentation, and it just highlights to me that lots of people want to talk about infertility and family building and associated reproductive technologies, and we're not doing such a great job. And for those of us genetic counselors who are embedded in CF centers, we have that opportunity to have these multiple discussions throughout. And I think for those CF centers that don't have genetic counselors, this is a huge opportunity. So thank you so much, Tina. And now we would like to welcome Dr. Richard Parad, and we are looking forward to hearing about his recent publication.
So first I have to acknowledge not just my publication, but these two incredible genetic counselors that I work with do the lion's share of the work here, and I know I'm probably preaching to the choir here in most things that I'm going to talk about, but I'm just going to try to delve into some of the two papers we've published on specifically how genetic counselors and genetic counseling is and theoretically should be integrated into CF care. So, arrows on here. Okay. And I have nothing to disclose except for some funding from the CF Foundation and Vertex, which supported this work. So we will talk about disparities in how genetic counseling is currently provided to parents of newborns who screen positive for CF. And intermittently, I'm going to go back and forth in how these families are lumped together. We talk about positive CF newborn screens, but the majority of those positives are actually not affected. Many are carriers. But how we deal with both carriers who were then ejected from the CF center after their sweat test is over and those who are affected, both will be dealt with as we go through. We'll talk about recommendations, which we recently published on how counseling should be done and what the content should be. And then very briefly at the end, I'll touch on a project Eleanor and Karen and I are working on to try to develop some telehealth solutions to improve access. So I don't think, again, that I need to tell this group that genetic counseling is extremely important to families who receive information from a positive CF newborn screen. The information provided by the counselor helps in all of these areas. Obviously, the counseling can be done by people other than genetic counselors, but as we'll touch upon a little bit later, it is not always presented to parents by people who have been maybe completely trained or appropriately or adequately trained to provide that information. And I think as we just saw in the last talk, even if you're very well trained to provide the information, it's hard to transmit it. A brief history of genetic testing with DNA and CF newborn screening. Most of you probably know that IRT was developed in the 70s in New Zealand and in the United States. Colorado was the first state that looked at CF newborn screening, but the CFTR wasn't identified until 1989. And it wasn't until the mid-90s, first in Wisconsin, where the IRT DNA algorithm was initiated, and that was in part of related to the research study that was going on there. Massachusetts took the first leap in 1999 to use a multivariate panel beyond just Delta F508 And this expanded the number of carriers that were being detected through newborn screening. And I think both Wisconsin and Massachusetts were pretty responsible when they included DNA in their newborn screens, in recognizing that it was important to include genetic counseling as part of the newborn screening algorithm. So we published a look back after our first 4 years, looking at over 1,000 babies who had positive CF newborn screens. Again, the majority of those turned out to be carriers. About 80% of them were appropriate by our criteria for receiving genetic counseling. There were some who just had transiently elevated IRTs and would not have been included in that group. Of those who were appropriate, 80% ended up being referred for counseling, and 70% of that group were completed. So we ended up with about 2/3 of those who should have had counseling got counseling, which is maybe not bad, but is certainly not perfect. Our estimates from looking at registry data and data from CF newborn screening programs is about 800 to 1,000 new affecteds diagnosed each year. There are probably about 6,000 who have positive newborn screens who should have genetic counseling because they're identified, the baby is found to be a carrier. And then there are somewhere around 30,000 existing families. So that's not a small number of people who need counseling at least once and probably multiple times. And we know that resources are limited. The interface between newborn screening programs, CF centers, and genetic counselors is sort of outlined in this diagram. The little blue arrows on the right are where genetic counselors, I don't know why this is taking off here, could intervene in the process. So the first arrow at the top may actually be prenatal counseling if the mother has undergone carrier testing. After a variant panel has been used or NGS as part of the newborn screen, then the baby would be referred for a sweat test, and there could be counseling either before or after that sweat test. And then I think, as we saw in the last talk, I'm not doing that. One session may not be, doesn't want to go to that slide. One session may not be enough, and so at the bottom you can see that probably there is a need, certainly for families that where the child is affected and you're going to put off genetic counseling to not necessarily do right with the intake, and also for families where carriers are carriers are identified but the child isn't affected, that there may be needs for interventions down the road. So all of those babies in the second yellow line, all those families need counseling, and really not.
Did you practice with the timer?
No, I did not practice with the timer. But I'll get off this slide because it doesn't seem to like that. This?
Yeah, let's use this. Try this.
Okay, so who does this counseling, and where are they from? And so we'll touch on this as we go through the next, if we can get to the next slide. Doesn't want to go.
Let's try it.
There it went. Okay.
Going up. Nope. Let's see, do you
Well,
wanna
maybe
go
I'll
out?
do it this way. Sorry,
Let's see
guys.
if my guy is here. We can see if the tech guy can help us.
Okay, I think I'm back in control. We'll see. So here's one small study from early in our experience in Massachusetts, just to get a sense of what the actual uptake is of testing after genetic counseling. This is a study out of our Tufts Center that showed that about 90% of parents agreed to have some testing. And of those, about 3/4 had both parents tested, and about 7% were found for both parents to be carriers. In Massachusetts, we, in that look-back study that we did after 4 years of screening, we hadn't really specified how the genetic counseling was going to happen, and we noticed in retrospect that three models had.
See something real quick.
I can keep talking a little bit. So we noticed three models of, from the 5 CF centers in our state. One model, in one model, the genetic counseling was done for families while they were waiting to have the sweat test done, if a genetic counselor could be available. A second model, the genetic counseling was done after the sweat test results were returned, but still on that same visit. And then the third model, when there was no genetic counselor available in the center, a parent would make an appointment to come back or to go to another site to see a genetic counselor on another day. And what we saw was that having the counseling done while the family was trapped in the sweat lab got us somewhere between 85 and 90% uptake. So some families did refuse. Maybe they had had some counseling, prenatal counseling, and didn't want it, or maybe there wasn't time, but 85 to 90%, pretty good. In the group where it was recommended that they return, we had about a 30% return rate. So we knew that probably wasn't our best model, but there really wasn't much of a choice for that CF center because they did not have a genetic counselor. It was in a remote area, and they didn't have a genetic counselor available on site. Great, that's it. Perfect.
And try using the touchpad instead.
Okay. So, let me just get back to where I was. Yep, okay, so here are the three models. And so another interesting piece of information we got from looking at CF Foundation registry data was that there is an entry in the registry asking about genetic counseling. How many, now these are the affected patients that have been taken into the CF center who should all have genetic counseling. There's no question about that. How you want to define what the genetic counseling is whether it be by the pulmonologist or nurse practitioner or a genetic counselor. We don't have that granularity from the registry at this point in time. But looking at 2018 back in infants diagnosed over the last 2 years, or about 1,900 children, and only about half of the parents were recorded in the registry as having received genetic counseling. And then looking at the 164 centers across the map, there was a wide spectrum in what percentage of parents had received genetic counseling, ranging from almost 15% said none of their families got genetic counseling to about 15% where everybody got genetic counseling. So there's a wide variety here. Again, we're scratching the surface of maybe why is that happening? Is it because of resources available or not available, or who's doing the counseling, or what standards are in place to say what should be done? So questions raised from these studies so far, why aren't all families counseled? What are the barriers to counseling? How do protocols and resources differ in different CF centers and newborn screening programs? And then what approaches would be optimal? There seems to be a theme this meeting for any of you who went to the newborn screening meeting yesterday, that developing standards now for newborn screening and intake of new patients seems to be a goal of the CF Foundation, to try to develop standards for things that we assumed that everyone was just doing okay up until now. So one observation that we made up to this point in time was that it seemed that the embedding of counselors in the CF centers was quite variable amongst centers. It sounds like Emory has a great situation, and I know my center in Boston sort of has an embedded person, and Eleanor is embedded. But this is the model from the CF Foundation. There's a multidisciplinary team, there's a core, and then there are recommended members. And the question was, why maybe should genetic counselors be added to this group on the right? So we applied for a grant for the CF Foundation to try to collect some information on what centers were, how centers were using genetic counselors or not using genetic counselors. And it's appropriate to do this counseling because all these major organizations have statements that say babies who have positive CF newborn screen their family should have genetic counseling. Most of this group of positive newborn screen, but they end up being carriers or not having CF, is a little bit difficult for the CF centers because those families don't maintain a continuity with the CF center. They go to the CF center to get the sweat test done and perhaps the genetic counseling done if that's where the resource is available, but then they leave if the baby doesn't have CF and the CF center doesn't feel as though it's their responsibility anymore. And actually the counseling kind of falls into a gray area there. Who should make sure that counseling gets done? If it were to be their patient, and I think we can also see that even when it is their patient, the counseling doesn't always get done. But should it be the newborn screening program and the State Department of Public Health that follows this through, or should it be the CF Center, or should it be the PCP? Those kinds of standards really are not in place. So the first of the two papers I'll tell you about from our group was looking at the variability of genetic counselor engagement by CF centers for CF newborn screen positive, what we called resolution. So a baby has a positive newborn screening test, gets referred for a sweat test. You need the sweat test value if there's just one variant, and then that there's a resolution which should end with genetic counseling. So two groups were surveyed, center directors for CF centers and their coordinators, and genetic counselors, and they were accumulated in different ways, and they were sent surveys. And we asked them questions about whether they used counselors, how often they used them, and in what way they used them. And again, here, surveys were sent to these two groups and accumulated in these ways. And then we stratified the answers back from each of those two groups kind of into three buckets that we called a center where genetic counselors were part of the CF centers. Those were the engaged ones, where genetic counselors were being referred to, so they were loosely attached, but they were valued, or centers that were non-engaged and they really didn't use genetic counselors for counseling at all. As you can see in the bottom in the red circles, the bottom line is that all three types are out there. There seem to be, if you add the engaged and the referral group together, that is the majority, but about a third of the centers really didn't seem to be using genetic counseling much at all. And when we asked genetic counselors the same question, what their perception was of how genetic counseling was being used for this population, it came out to be, pretty much the same perception as what the CF Center said was happening. This is a summary of from surveys from the CF centers, what they said of some of the points. Obviously, and again, if we look at them as the engaged or the non-engaged, it's not surprising to see mostly good things were being said by the centers that engaged the counselors. They felt there was value, and they were helpful, and they actually made things work more efficiently, whereas the non-engaged centers said they sort of didn't need them. They had time to counsel with the staff that they had. And when we asked the genetic counselors, Most counselors in the engaged centers felt that they were doing good things, that they were adding value to the team by doing the counseling, and they were being utilized well. And both groups, counselors from both groups felt that they were pretty comfortable in doing sort of this sort of basic counseling, although as you'll see when we get to the recommendations, that there probably is a need for, if you're a genetic counselor that just does cancer counseling, we may actually need better resources for people to, help train them up if that's the only kind of genetic counselor that's available in a center. I'm just going to skip ahead since I think I fell behind a little bit here. So the conclusions from this study were that there are very complex relationships between CF centers and genetic counselors. We were not able to convince the CF Foundation to add that little cartoon to the recommended team. So we decided to change our strategy a little bit. It's a little bit of a charged issue because some centers perceive that this is a cost that they to have a counselor embedded that they can't sustain. There are really a lot of differences in staffing between the different sites, and although the surveys generally had suggested that this was a good thing and it helped the CF centers, we didn't feel that we could really make a strong enough statement to convince the CF Foundation to say this should be sort of mandated for each center. And they don't like to mandate anything because I think it ends up being a lot of money. But understanding, getting some insights from these questionnaires about what the dynamics are, what the resources are like, I think was helpful to us to move on to this next project. So given that things are the way they are, and CF Foundation is not saying you must have, they do, I think, loosely recommend that there be a genetic counselor used by the center. We thought it might be helpful to develop some consensus guidelines about what these sessions should be covering, how information should be presented to families, and especially if many of the caregivers who were doing counseling were not genetic counselors, that we set some kind of standard. And this hasn't really been studied that well, but using the Delphi process, it's possible to sort of get a consensus from experts and then put forward at least a first stab at proposing what should be done. So we proposed to develop, and this again was part of a grant from the CF Foundation, from the Newborn Screening Quality Improvement Group. We had proposed to determine some best practices for genetic counseling for CF newborn screen positive families, and describe some models of ways to deliver this information to families. And this starts to bring us into the next project, which we fortunately have ended up getting some funding to do, which is to try to find a model for actually using telehealth in trying to provide this information to families. So this paper, which came out two years ago, I've kind of lost from the pandemic, it came out electronically and then finally in press, was an effort between Eleanor and Karen and I and a work group, which was had multiple stakeholders, including parents and CF clinicians and genetic counselors. And we met in Nashville, I think, and did our first or second round of a Delphi process where the three of us had developed a bunch of statements. We circulated them, and then people voted on them, and any statements that got greater than 80% consensus, we ended up including in the final document. And one thing we did sort of start with was to ask what groups absolutely, need genetic counseling. You can kind of put them into this 9-cube grid if you look at number of variants detected and sweat chloride. And the cube on the lower right there, the 47%, are no variants detected. The newborn screen was positive. There were no variants detected, and the sweat chloride was less than 30. So those are the IRT, very highly elevated group mostly, and we couldn't get a strong consensus that that particular bucket absolutely should require, but all the other cubes fell into the group of those who should get genetic counseling coming out of a positive CF newborn screen. So I'm very quickly going to run through what the consensus group had consensus on at greater than 80% and was published in that paper. Genetic counseling is recommended for parents of infants with a positive screen. Every CF center should provide resolution of positive screens and ensure access to genetic counseling for parents. So this is an important one, and I think a step forward to have it in its own document instead of buried in some of the other ones. The timing should be optimized. It's not necessarily the same timing as right for each family. Parents should be informed right at the beginning when the test newborn screen is positive that about the purpose and the availability of genetic counseling so they know to expect it and why it's important. And that should go to sort of the PCPs most likely. Ideally, a genetic counselor and or someone who has expertise in CF and in counseling should inform the parents. The needs of the parents may be present at different times. It may be as soon as they get the result from the newborn screen. It might be when they walk in the door of the sweat lab, or as was done in my center, we felt that the optimal time was after the result was available so the counseling could be specific on what the sweat chloride value was. But that need, it may be different for different families. Again, access should be optimized for parents in conjunction with the sweat chloride test being performed. As I showed you those data, you'll get 90% if you can somehow coordinate it with the sweat test, but you're going to lose a lot of people if you ask them to come back. Follow-up should be made available to parents, so one session may not be enough, or they might it might be cut short, so there should be a way to have them come back if they need it or have questions later. It should be tailored to the patient. The core components should be evidence-based and delineated with guidance of the CF Foundation, and this is something that hasn't quite been done yet, but might be an educational document that appears, or extension of this guideline. Parents the session should include discussion of reproductive risks and testing options, and should be in a non-directive fashion. And again, without a guideline present, with just the CDC and CF documents that say counseling should happen with no standard on what the content is, we don't really know how much each session gets into reproductive risks or whether testing is offered. As a physician, one of the many things I appreciate about genetic counselors is that they can arrange the genetic testing, which is a pain in the neck to do if you don't do it all the time. And I could see very easily that non-counselors, say in a CF clinic who are busy doing other things, could explain things and then maybe not focus so much on whether the parents want to have carrier testing done, which would be very important potentially for their next pregnancy. And then finally, there should be training available, and this is something else that needs to be developed. There should be written information that can be given to the family when they leave, so they have something in hand that they can go back to that may help with their retention. And association of a genetic counselor with the CF Center, we think would facilitate better counseling, but that's about as close as we're going to get to mandating that a counselor be embedded at the moment. There should be ongoing association in the CF Center with a genetic counselor who can also help with other issues such as pharmacogenomics, where genetic counselors have become more and more important as we try to sort out, what drugs can be given to what patients. So this is a summary of those statements for sort of best practices about providing genetic counseling services to families of positive CF newborn screens. And just the last couple of slides about where we're going in the future. There are experiences out there right now, and the pandemic, one of the only silver linings of the pandemic has been the major step forward for the use of virtual healthcare approaches. We know that UConn has been doing this for a while for CF newborn screening counseling, using remote resources from Florida to counsel families in Connecticut, but they've had some very good experiences with that. I'm not sure that that's been published yet beyond an abstract or a poster here. We also have had a lot of communication with NIMAC and some of the regional genetic networks on sort of best practices for what is being called telegenetic counseling as a sort of sub-area of virtual care. And then certainly there are now companies out there that are doing this, and billing insurance companies that are virtual companies that could be utilized by CF centers right now if they did not have a genetic counselor. But we thought it was worth trying to develop a model that we could propose that the CF Foundation support as a way of getting genetic counselors in. So a potential solution would be to develop a centralized genetic counseling telehealth service that could be made accessible nationally, potentially supported by the CF Foundation through the CF centers. So if they don't have a genetic counselor or one's not available right away, they could schedule a phone appointment that could be happen right there in the clinic, or it may be more likely that that group that was going away and not driving back to find a counselor in another office building might be willing to do that from home. So we're currently funded by the CF Foundation and Vertex to try to develop a model for doing this. We're doing focus groups of all the different stakeholders that would be involved in developing this program, and maybe at a future meeting we'll be able to tell you about the model we've designed and its implementation with hopefully integration into CF care centers. And I think that's the end. So,
Thank you so much, Dr. Parad, for the excellent presentation. And accessibility of genetic counselors within CF centers is a topic that's very near and dear to all of our hearts, especially my co-moderator here, who's been at this for a very long time and has much expertise. So we have about 4 minutes, and we did have some questions that were submitted, and let me just go to one that was actually for one of our presenters. If you would not mind, Sabrina and Tina and Kim to come up here in case there are any other questions. I know we have a short time, but we'll try. So the first question is for Sabrina, and that question is, do you know the mechanism behind cataracts for Trikafta?
Yeah, great question. So the question regarding do I know the mechanism between cataracts and Trikafta? No, and it was an observation that was made only in juvenile animal models. I don't know the mechanism. I think there are some studies out there, and I'd be happy to find that for you if you want to email me. But yeah, unfortunately I don't. Sorry.
And I did respond to a question about Sabrina's email, and that's posted, so hopefully you can see that. So then there was a question by Aaron Wilson, and at my institution, University of Kentucky, I've been told a genetic counselor cannot meet or bill for a counseling session unless the patient is also evaluated by a geneticist. This is particularly problematic as the wait time for an appointment in the PEDS genetics clinic is over 12 months. Is this scenario encountered in other states? And yes, I hear back there. What about some of the genetic counselors here? Kim or Tina, Eleanor, anybody else want to comment on that?
Do you want to step up?
I'll comment that we're in a similar situation in South Carolina, and it's disappointing. The genetic counselors can't bill independent of a physician. We don't have licensure in South Carolina yet. I am fortunately embedded with our pediatric and adult CF care teams and our ancillary providers like myself, RT, dietitian. We don't bill separately. So there's no problem providing our services in the center, but for the positive newborn screen babies, I literally have to corner them in the sweat test room. I can't drop a facility fee. I can't have them scheduled to my template. There is no way around that. Our wait time for a geneticist is 8 months, and it's not something we want to clog up our peds Palm Clinic with a likely carrier, so I'd love to see a better solution. I'm really excited about this grant that Dr. Parad and Eleanor have. I think that is likely a really feasible and scalable solution.
The other thing I would just add is that genetic counselors are not currently recognized by the Centers for Medicare and Medicaid as independent providers. There's been a bill in Congress many times. So we do need some advocacy if you want a genetic counselor. There is a bill that can be supported either by institutions or by organizations, and I'd be happy to be a point person for that advocacy as well.
And we are hopeful, though, that that is moving forward. And at our center, we do a facility fee, so I can drop a charge for a facility fee for the patients that I see that are separate of the CF center, but I'm also embedded in the CF center, and so my seeing patients does not cost them anything.
Mine's similar to hers, where you kind of absorb the cost.
And now, let's see. I think Dr. Parad, you had a question, and I think that was related to Sabrina's case. Was the sweat chloride concentration measured again before stopping maternal meds?
Kim.
Oh, sorry. Yeah.
So the infant sweat chloride was only measured once in this case of the infant. It would be interesting to get serial values, but at this point in time, we only have the one that was 64 and 62 on day 27 of life.
I have one other question for Tina, actually. We work so hard to try to figure out how to define what we do and the benefits, and I'm curious about your survey and if that is something that might be used in other future, well, first of all, how did you develop the survey, and then what future directions do you see it could be used in?
Yeah, that's a great question. So we weren't able to actually validate the survey in itself, mainly because I'm only in school for 2 years and didn't have the time. But we kind of use bits and pieces of validated surveys in addition to kind of changing up based on CF. The survey is readily available associated with the publication, so everyone has access to it. In future directions, I think we just had a lot of kind of mishaps. I think with technology also advancing, there's better softwares out there where I think you could get a lot more information and get kind of more data points. So I hope that can be used in honestly any condition for genetic counseling. It can be a very simple genetic counseling survey to see how a certain learning model is retaining information at point 1, 2, and 3. I think it's pretty adaptable for any genetic condition. I would love to see it be used, of course.
And great. And clearly from your data, we need a 0.4, 5, and 6
yes.
as well.
Yes, we do, definitely.
Good, thank you.
Thank you so much. And let's see, what time is it? It is 9:34. I think that if you have any other questions, you're welcome to stay back. Thank you all so much for coming.